everyone in Brazil. This is another live session of the International Seminars of the Stricto Sensu Postgraduate Program in Health Sciences at Einstein for the year 2024. The International Seminars are an initiative of the Einstein Stricto Sensu Postgraduate Program aimed at internationalizing its curriculum. My name is Alexandre Marra, and I'm a permanent faculty member of this program affiliated with the University of Iowa. It's important for everyone to engage in international seminars by asking questions, clarifying doubts, and responding to the satisfaction survey that will be provided via link in the chat. Now, I will pass the floor to Dr. Guillermo Rodriguez Nava, who will have 35 to 40 minutes to speak. Dr. Guillermo is a second-year infectious disease fellow at the Division of Infectious Disease and Geographic Medicine at Stanford University, California, USA. We'll talk about empowering fellows, the vital role of mentorship and Latin American connections. Thank you very much, Guillermo. The floor is yours.
All right. Thank you so much, Alex. Thank you so much, Sandra and Einstein, for having me here. Let me share my slides. All righty. Can you see my slides all right?
Yes, perfect.
All right. So yeah. All right. All righty. So thank Alex for the introduction, and I just wanted to mention that so I'm originally from Mexico City. There's a few beautiful shots not taken by me of the city. It's one of the largest cities in Mexico, and I guess the world. I was born and raised, and I did medical school over there. It's taking a little bit. The slides is not moving.
You can try again. Let's see if it's moving.
Yeah, I'll reshare.
Sure.
Okay. I apologize.
No
All
problem.
right. Um, Original. Okay. All right. All right. All right. Yeah, passing the shots from Mexico City. So this is a brief summary of my career so far. So as I said, I did medical school in Mexico City in the Facultad de Medicina at la Universidad Nacional Autónoma de México, which is one of the oldest and the most important university in my country. Then I moved to the United States in 2019 to do internal medicine residency in North Chicago at a small hospital, 200-bed called Ascension Health San Francisco Hospital. And then in 2022, I moved to Palo Alto, California for infectious disease and hospital epidemiology training at Stanford University. And below, it's a brief summary of all the research I have been involved, starting from the last year of my medical school in Mexican Emerging Infectious Disease and Clinical Research Network, and COVID-19 epidemiology management and outcomes at my community hospital in Chicago, and some related work with infection prevention and antimicrobial stewardship groups in this hospital. And then at Stanford, I've been mostly involved in diagnostic stewardship or excellence, we call it, and then emerging technologies in infection prevention and hospital epidemiology. So one of the most commonly questions that I always get asked is why did I decide to come to the United States? And I guess it started from the very early. I am kind of a nerd, and I've always been interested in this kind of TV shows or movies that do a lot of emphasis in science since I can remember. And Back to the Future is one of my favorite examples. Is my favorite movie, and I don't know. I'm always been into science, but Mexico has a lot of issues in terms in of science and spending money for science, and just a clear that it was clear to me that if I wanted to do something that would be relevant, I will have to move out. And it's a no-brainer. You can just see here total Nobel prizes, and I guess it was a wild dream back then when I was a kid, but it is important to consider this fact that most of the Nobel prizes in the world have come from the United States, whether they're citizens or people from other countries working there. Even the majority of Nobel prizes from Mexico, they were working at the United States at some point. And then this is just the reality in terms of money. The amount of money that Mexico spends of research and development is nowhere compared like to the United States or even Brazil. And the other side of this coin is the amount of work that medical residents, students, and physicians have to do in Mexico. It's almost twice as much, around 90 hours per week as compared to 50 hours per week here. And the amount of night calls that you have to do back home, it's just a lot. So most of the clinicians don't have the time to get engaged in research. You either have to give up patient care and dedicate your time to research, or give up some other aspects of your life, like family and whatnot. So that was the main reason I decided to come to the United States. But why infectious disease? I guess there's two reasons because I decided to do that. So when I was in med school, I already knew that I wanted to come to the US to finish or complete my training, but I didn't know that I wanted to do infectious diseases. I actually wanted to do neurology, so I applied for an elective as a medical student to the University of California in San Diego, and these were the options that were given to me. So I just placed infectious disease on second. I really didn't care about the other options other than neurology. So I guess it was some sort of luck that infectious diseases was second, and that was the option that actually was given to me. So even as a medical student, I had the opportunity to come to the United States and practice or see how they practice medicine. And it was a life-changing experience because now I'm here in California, and that was the moment I decided to do infectious diseases. And then the other thing that I like about infectious diseases is that it's very cool, and everything in this planet is connected to infectious diseases. And then one example that I loved and I'm recently giving a lot is the fact that tuberculosis caused World War One. Before antibiotics, it was pretty much a death sentence. You get TB, you're probably gonna die. And just turned out that three of the six would-be assassins that were sent to kill the Archduke Franz Ferdinand had TB. So the three guys that didn't have it chicken out, and then I think one of them didn't even did try to assassinate Franz Ferdinand, but it was a very shy attempt. And the other three guys that really attempted it had TB, and they knew they were gonna die, so they didn't have anything to lose. So at the end of the day, this guy Gavrilo Princip, who was the one who managed to kill the Archduke, he died of TB a few years after he was captured. So I know this is an oversimplification of what triggered World War One, but it's a very cool example of what I'm saying. Everything in this planet is connected to infectious diseases. And just back to my career, one of the early projects that I was involved in research was about why do we sleep. We're trying to figure out what, because believe it or not, no one knows why do we have a sleep and why do we dream, stuff like that. So we were testing sleep as a way to consolidate memory on this they're called crayfish. So when they're on the wild, they fight and they remember who's the alpha. So what we used to do is to sleep deprive them after they have decided who's the alpha and measure the amounts of fights that they will have afterwards. So it was significantly the fact that the crayfish that wouldn't sleep, they will forget more frequently who was the alpha and they will fight more. But anyways, it's just an example of the early research that I was involved in my medical school and the fact that I wanted to do neurology on neurosciences back in the day. But then at the end of my medical school years, when I already knew that I wanted to do infectious diseases, as I mentioned earlier, I joined a research network in the most important hospital in my city and the country to do surveillance and test the community-acquired pneumonia guidelines and the impact in management of patients with pneumonia. And so it served two purposes: monitor respiratory viruses and then evaluate the Infectious Disease Society of America guidelines for the treatment of community-acquired pneumonia. It was pretty cool research because I will spend the day in the morning collecting nasal swabs for patients with influenza-like illness, and then I will spend the afternoon doing chart review, which back home implies going to the basement and collect the paper charts and then fill up like a lot of forms. So that is chart review, nowhere compared to whatever I do now, which is just computer work. And I guess I'll just summarize here what we did in terms of the community-acquired pneumonia guidelines. There was a period of time in the hospital that it was free for all. Everyone will do whatever they wanted, including ordering procalcitonin. Then in 2012 and 2013, the guidelines were available, but there was no formal protocol. And then by the time I came in 2015, there was a formal protocol. And that was the other aspect that I was doing, is collecting procalcitonin on any patient that was enrolled in this study at the day of admission, day 3 and day 5, to see if this test will help in any way in patients with community-acquired pneumonia. So I reviewed a lot of paper charts. That was a lot of work. It was a whole year just dedicated to this. Around 1,800 records of patients with pneumonia. A lot of elderly patients in this hospital, and around 800 episodes of pneumonia in 732 patients. Of those, there were 229 patients with community-acquired pneumonia. And this is from the period that it was, the guidelines were available, but it was still a little bit of free-for-all. So only about half of these patients received a procalcitonin test, and the median day of collection was 4 days, but as long as 43 days. And then only around 8% had one procalcitonin done in day 1. And about 1/3 of these patients had 2 or more samples, which is the recommendation is to get at least 2, one on admission and one on day 3. And 40% of these had a value that was considered abnormal, but the vast majority of them actually show a decrease in procalcitonin. And this is just the antibiotic practices in this time period. No change. A lot of patients receive broad spectrum antibiotics for community-acquired pneumonia. And then as a part of my specific research project was to evaluate the role of procalcitonin as a predictor of mortality. And this is an ROC curve. You can see that it wasn't useful, at least the way they were collecting it, which was not a protocol. I never get to publish this, but it was a very nice experience because I learned chart reviewing, I learned how to collect informed concerns, and I learned how to record data and a little bit of statistics. And then after I graduated, and I was I was taking the test to come to the U.S. I was also looking for opportunities, more opportunities. I had been here as a medical student, but I wanted to do a little bit more to get, letters of recommendation or people that would speak good about me when I was interviewing for residency positions. So I emailed a lot of people, and this is just a fragment of I guess, some of the emails I could retrieve. I will just look websites and email, get the emails of the people from PubMed or whatever. Sometimes in the university profile, you can find these emails. So I will email a lot of people, and most of the times you won't get a response. But I will say around 10% of the times I will get a response, and very nice opportunities. For instance, this one at Wake Forest University, I ended up turning down to go to California, but it was a nice project on endocarditis, and probably they had published good stuff. They had a lot of patients, and it was going to be a lot of chart reviewing and things that I was used to. I did ended up going to Texas. Some physicians from Mexico responded very nicely to me and gave me the opportunity to go to San Antonio. And then from San Antonio, I went to Mayo Clinic in Jacksonville, Florida. And it was a nice opportunity as well. Actually, that was the first time I attended an allergy or international meeting to present a case of voriconazole porphyria. I get to work with an allergist and immunology in Mayo Clinic. And I will say that he served as one of the first mentors that I had, because with him, I published two case reports. These were my very first two peer-reviewed publications, and he had a very active research machine at Mayo Clinic in Florida. So he's very well published, and he had a lot of postdocs working with him from South America, actually, mostly from Colombia, if I recall. But everyone was very nice, very productive. Um, and then I met this guy in Mayo Clinic, Jacksonville. He was another IMG that inspired me a lot. I think he was a PGY2, or I guess what we call residency year 2 or 3 of the 3 years that you do in internal medicine here. And he had already plus 30 publications, and he gave a lecture on how to do research. And I was very impressed. And I decided to follow his steps, and I put myself a goal of 30 publications at least during my resident time. Um, Speaking of residency, as I said a little bit before, I did residency in Chicago. Obviously, I didn't take this picture, but Chicago is a beautiful city, and I love it there. Had a great time. This is a aerial picture of the hospital I train on. Small community hospital in the north side of Chicago, around 200 hospital beds. And I will say that my residency training was very well impacted by the COVID-19 pandemic. I started in 2019. I had 6 months of normal residency, and then after that was the hospital became COVID-19 only. But I had a lot of fun. I met my family there, my surrogate family there. I had a lot of friends, and I get to present also a couple of the research um, or the research projects that we did as residents. And there's always something you can do, and this is very important because as I guess I should explain a little bit here. In the United States overall, there's hospitals that are affiliated to universities that they call them university hospitals. I presume that's the case with Einstein in Brazil, and there are some other hospitals that are not affiliated with university and they call them community hospitals, which is a little bit harder to do meaningful research, and I guess I will quote unquote meaningful, because you are not affiliated with a big academic institution. You don't have the names to back you up, and things like this. But there's always something you can do. And before the COVID-19 pandemic started, there was an outbreak of measles cases in the United States and Mexico. And then I came across with this CDC database that has a lot of adverse drug reactions to a lot of medications, including vaccines. So I thought like maybe we can use this public database to do some work and try to explore or debunk the reasons that people think that vaccines are not safe. And in this case, the measles vaccine or the MMR vaccine. Uh, so I used that data to prove that the MMR vaccine didn't have a significantly higher number of adverse events compared to other vaccines other than orchitis. Um, and it's generally a safe vaccine. And even when you consider severe orchitis, like something that will put you in the hospital or will have like permanent consequences, it's not significantly different compared to other vaccines. So that was one of my first peer-reviewed publications that was in a case report, and it was actually editor's choice in the Open Forum of Infectious Diseases. And I did that as a resident in a community hospital with no affiliation with any university, just out of curiosity and exploring the tools that were available to me. But then with the COVID-19 pandemic, besides the tragedy of this pandemic, I think it opened up a lot of opportunities to me. And Chicago was one of the first cities in the United States to get impacted by this first case March, in January 2020, actually, the end of January. The first case in our hospital was in March 2018. And by then, there were a lot of publications from China, some from Europe, and some from the United States, from university hospitals, as I mentioned, but not a lot from hospitals like the one that I was training. And something interesting about the hospital that I did residency is that it was surrounded by a lot of skilled nursing facilities, nursing homes, people where places where they host like the elderly and sometimes sick people that they cannot care from themselves. So it was a unique population, and there was not much literature regarding COVID-19 and outcomes in these patients. So me and my friends decided to start a live database that we call Project COVID-19, just recording all the clinical characteristics of these patients and try to, to figure out the outcomes, what was happening to these people. And we did get to publish some nice papers about this. Unfortunately, I came across with one of the variants that I was speaking about earlier. Like and not to brag, but I consider this paper was of enough quality to be published in JAMA because it was unique and it was similar to other papers, but just reflecting what was going on in the community. But I presume that just because I was a resident and I didn't have anyone with a name to back me up, I had to lower my standards and publish this in the Mayo Clinic Proceedings Journal. But we showed that patients from the skilled nursing facilities had 3 times the hazard of death when they had COVID-19 as compared to patients coming from home or other places. And then this is another thing that we could figure out from our data is like patients that were taking statins before getting admitted with COVID-19 were progressing slower, had a slower progression to death as compared to the patients that were not taking statins. And this was later disproved by a randomized controlled trial, but at least we were one of the first to describe this possible association, and that led to the randomized trial later. And then another thing that came out of this was this, I guess it was national collaboration because we had some patients with HIV and COVID-19 co-infection. We shared data with Dima Dandachi, the first author of this paper. So she then got to publish the clinical outcomes of patients with HIV and COVID-19, finding out that the lower the CD4 cell count, the higher the odds of death in this population. And so I learned a lot, taught myself statistics during this time. I learned how to collaborate with other people across the country. So it was a very nice experience that came up from something very, very bad. And then besides COVID-19, just being involved or being in a small hospital allowed me to join a lot of committees like hospital, the healthcare, not the healthcare, the infection prevention committees and the antimicrobial stewardship committees, and test some of the interventions that they were doing without a lot of evidence. And just because the committees were small and I was actually the only physician involved, they listened to me and they allowed me to present data and change some of the practices that they were doing. And one that I like very much is this practice that they used to do on universal oral vancomycin prophylaxis to prevent Clostridium difficile infection in hospitalized patients that were either receiving blood spectrum antibiotics and either had a recent admission with exposure to antibiotics or had been admitted to the hospital for longer than 7 days and were receiving some sort of anti-acid. And so they were doing it for all these patients that made this criteria. So we decided to do a propensity score matching study and before and after the intervention. And we pretty much find out that the intervention was not being effective in preventing hospital-acquired C. diff infection. And patients coming from these skilled nursing facilities and they were admitted for a longer period of time, they did have a higher risk of developing hospital-acquired C. diff infection. So the hospital decided to back down on the universal prophylaxis, and they just gave it to this subset of patients that met the prior criteria that I showed you, but they were coming from nursing home and have very long hospital stay instead of all the patients that were on broad spectrum antibiotics and anti-acids. So it was a nice experience. And this what I learned the most about this paper or about this work is mentorship, because I wasn't the one that did most of the work here. It was this trainee. She was a resident from a lower year, and after we did some work, some other work together. She managed to get into pulmonary and critical care fellowship in University of Pittsburgh. And so um, it was a very satisfactory experience. Um, so after I completed residency, and I guess I should check my time. I came to Stanford. Um, this is a picture of my colleagues in my class, and a picture I took myself from of the hospital. And it's been an amazing experience over here. My first year was mostly dedicated to seeing patients, and still I got a lot out of it. I was lucky to be between the group that first or did one of the first descriptions of myocarditis that were attributable to mpox in two patients. I think back then, just there was a case from Canada, and actually, after that, we started collaborating with this group in Canada. And I think we have a paper under review on a large case series of myocarditis and mpox, and I think some sort of systematic review. And then um, I was lucky to see another interesting case of a patient living with HIV and very tricky coccidioidomycosis infection in the brain that I was able to later present in I guess, the biggest microbiology and infectious disease conference in Europe. And this was also an amazing experience. And it just came in from just came out of clinical work. I wasn't even like doing a lot of research back then because I was very busy, but just the exposure to the clinical experience allowed me to have these opportunities. But the second thing that I love about my training here at Stanford is mentorship. So as I said, I think earlier in my career, I had one mentor in Mayo Clinic in Jacksonville. But pretty much after that and in residency, I was alone doing things on my own. And I think I didn't have that many opportunities because of that. But I guess I managed to get some stuff done. But here, having a mentor has been the most valuable thing that I could say. And this is a very interesting publication in Nature from last month on how to win a Nobel Prize. And there's a lot of takes, and I think there was a lot of backlash about this publication. But the most interesting finding is like um, you are more likely to win a Nobel Prize if you work for someone that already won a Nobel Prize. And then this guy, John Stewart, he won a Nobel Prize, I think, in the early 1900s. And then from him and all the all the mentees that came after him, this is the cloud of Nobel Prizes that can be traced back to this guy. And to me, this speaks about mentorship, and this is a picture of my mentor, Jorge Salinas, who Alex knows very well. And that's where I learned about this paper. Having a good mentor opens a lot of opportunities, and there's no clear example that this cloud of Nobel Prize winners. This is another pictures of some other pictures of my mentor and I. He's been very supportive in all the aspects, life, academic, and otherwise. I we meet every once a week at least, and we speak about all things life concerning, from work, as I said, research projects, but how is the job market going, or how am I doing personally, and that's very valuable. And he's helped me a lot with connections, and I wouldn't be here if it wasn't for him. I wouldn't know Alex, and I wouldn't be being speaking to you. But beside this another example that I like a lot, a paper I published with Alex and Jorge, a systematic review on the treatment of syphilis. And this was very timely, because this was a question that I was having in my head a lot, like why can we use some other things other than penicillin to treat syphilis. So I guess we finally got an answer for that. But it was another example of the connections that I was able to make just because of my mentor. And this is another of couple of examples on the connections I have, thanks to Jorge, with Dan Dikema, who's considered one of the gurus of diagnostic stewardship in the United States. And then below, it's work with Catherine Goodman and Dan Morgan on artificial intelligence and hospital epidemiology. Again, these two people are very well published, Dan Morgan and Kathy Goodman, and they know their stuff on artificial intelligence. And I wouldn't be working with them if it wasn't for my mentor. And he always had a lot of ideas. I guess two brains are very uh, two things. Two brains think better than one brain, or at least that's a saying that we say in Mexico a lot. So um, he has a lot of great ideas. For instance, he was the one who got me involved in one project we have in the hospital on the correct use of blood cultures, or what we call diagnostic stewardship in blood cultures, where we were able to reduce the utilization in a medical intensive care unit that cares a lot of lung transplant patients. And this work was recognized in the Society of Healthcare Epidemiology of America just this year. So I wouldn't have had this award if it wasn't for my mentor and the ideas that he has. But he also encouraged me to develop my own ideas, and I think this was a co-idea that we had. I always been interested in computers and artificial intelligence, and so this is a paper we just published on an LLM we have here to identify central line associated bloodstream infection that showed to be not bad, almost as good as a human and faster, and it was highlighted in the infectious disease week just last month as one of the most influential publications of the year. So all of this thanks to mentorship. And as I said, he's opening doors for me in terms of jobs, but also in terms of like other opportunities, like giving talks. So I gave a talk at ID Week last month, and then earlier this year I was able to give a talk in my home country on respiratory viruses and their transmission in healthcare settings. Again, probably wouldn't have had this opportunity if I was just rolling on my own. And then collaborations in the United States and international collaborations. This work on blood culture stewardship, it's been a collaborative work with Johns Hopkins University and other big academic institutions in the United States. As I showed in the earlier slide, but this is more data regarding the whole hospital. The decrease in utilization has been significant, and we have been able to save money to save us trouble with the current global shortage on blood culture bottles. And it's been a nice experience overall. And international collaborations, we are developing collaborations in Mexico and Brazil. If I'm not mistaken, this should be Einstein Hospital. I hope the Google didn't lie to me. And then also in Peru. um, and I think I'm almost approaching the end. And if anyone here is interested in infectious diseases, I will say that healthcare epidemiology is the branch of infectious diseases that has it all. And you can try to prove me wrong, but I will probably find an example to prove that that is the case. So we do research. Actual what people think about when they think about research is lab-based research. So we've been doing that. We've been testing resistant genes in hospital wastewater, antimicrobial resistance genes, and this is a result of PCRs that I did myself, where I myself extracted DNA and RNA in the lab, and I did the DD PCR myself, and we were able to detect some resistant genes, even for carbapenemase resistance genes in hospital wastewater. And we also did genomic sequencing in blood culture isolates before and after a practice that is called contact precautions, finding no difference of the genetic relatedness of the microbial isolates. Long story, but this is just to like show you that in healthcare epidemiology you can do basic lab-based research. Stewardship. Usually, people think about antimicrobial stewardship and the proper use of antimicrobials. I have been involved a little bit, but just a step earlier step on antimicrobial stewardship, which is the diagnostic stewardship. If you don't test for an appropriate infection, you're probably not going to use antibiotics inappropriately. So education, as part of this project itself, I have been talking to a lot of people, a lot of residents, a lot of fellows that are not only infectious diseases. Just a couple months back, I spoke with the surgery residents about this project and the proper use of blood cultures, and we're actually writing an opinion paper on the use of on diagnostic stewardship in surgical specialties. Um, Industry, we have had talks with some industry partners. They're trying to sell us stuff or not sell, but just provide equipment for us to do research without paying any money, I guess, but just as a way to advertise, I will say, probably their machines. I guess we talk with these people that were trying to loan us or maybe sell us a machine to analyze wastewater. I think at the end of the day, we decide not to do this, but it's just an example of the things that you can do. You can get involved with industry partners, get devices, get them tested, and get academic work out of it. Global health. Jorge has worked in Liberia on ventilation in low-resource healthcare settings. This is a prior fellow that was working with Jorge, presented this at the Society of Healthcare Epidemiology of America. You know, very interesting work. Public health as well. For instance, this work on mpox and the use of a deep learning algorithm or artificial intelligence to classify skin lesions that may look or may not look as mpox. And Jorge is still working with another infectious diseases fellow on public health and mpox. Even transplant ID or transplant infectious diseases. Like we had a patient or we had to evaluate a case a few months back of a possible transplant transmitted TB. So you, as I said, if you are interested in infectious diseases, healthcare, epidemiology, it's all inclusive. You can develop pretty much any career you want in infectious diseases just by doing healthcare epi. And just to put it simple, ID is the best, and I'm happy to take any questions. These are pictures of my bunnies and a wild bunny, and the fact that I could get tularemia. So if I go to a hospital, please, Alex, tell people that I have high risk for tularemia. Thank you.
Wonderful, Guillermo. I'm totally in shock how superb is your presentation because, you know, as a ID fellow, you should, take knowledge, share so much knowledge. You're like a full professor, not a ID fellow. Congratulations. I'm
Thank you, Alex.
totally, it's amazing presentation. I'm so, wow, grateful for you accept our invitation to be here with our medical staff and healthcare personnel from Albert Einstein. And we hope that we can keep working together in research projects. And I have a lot of questions, but I will open for people in the floor. If you have questions, please. João Renato is here. João, you know. Can start the first question. Please, João, you can ask Guilherme. Sandra?
Oh, João.
Oi, doutor Alexandre.
Oh, você pode dar permissão para o João fazer uma pergunta?
Sim, claro.
Ótimo, obrigado. Please, João. The floor is yours.
Bom, então, it's a pleasure to have seen your lecture. You seem that you have done a lot of different research in many different areas, especially infectious disease. That is our area of interest. And it's amazing how much have you done. We are not, you're finishing the Nobel Prize, maybe we, that's not, we will not get this, but anyway, we think that we can do a lot of things in studying together the progress that you are following in the metagenomics and other related subjects in infectious disease. And I'm sorry if I don't follow all your lecture, but maybe you can speak a little bit on the future of these new technologies and how you think they will apply it and how they will change the diagnostic area in infectious disease. That is would be my questions, but first of all, congratulations for everything that you.
Thank you, Joao. It's a pleasure working with you as well, and it's another collaboration that I enjoy a lot and came out of a good mentorship that I have here with Jorge. And just to briefly answer your question, in terms of metagenomics, for diagnosis, I think there's a lot of opportunity. And just for instance, again, thanks to the position that I'm on, I was able to attend a meeting on antimicrobial resistance in the border of Mexico and the United States, which is a big problem because sometimes the patients from Mexico with resistant bacteria seek healthcare in the United States, but it's hard to trace them. And sometimes there's not a lot of mechanisms to trace these patients. And it's the problem is even worse in Mexico because sometimes they don't have the means of testing because all these cultures, machines and all the supplies that are needed are very expensive. So one alternative is to do genomic sequencing for these patients that may be cheaper in time and faster and won't require all the people that is required to run a microbiology laboratory. All these benches and all these lab techs working on the cultures and whatnot. So you may overcome these issues with genomic testing obviously if this becomes cheaper and faster. And so that's one of the use cases that it's in my mind a lot. And in terms of healthcare epidemiology, I think the better these techniques become for sequencing, the more interesting results we will have. And just to give you an example, a lot of people are using short read sequencing nowadays to track outbreaks in hospitals. But the funny thing is that when they look for relatedness, there's not a lot of relatedness. So there's something else going in the background. And what we have seen doing long read sequencing is that mobile genetic elements are at getting transmitted at a different rate than the bacteria itself. So maybe it's all these plasmids that are moving around instead of the bacteria. So that's another interesting take that we're just learning from this work.
Thank you.
Do you have another question, João?
No, that's okay. I'm very happy to start a collaboration with Guillermo and keep going on those lines that we are that is starting around the world, and I think that we will have very interesting results in the next near future. Thank you.
Yeah, thank you very much.
Pleasure.
Yeah, that would be a very interesting collaboration between you and Guillermo, studying wastewater, doing the wastewater surveillance, using metagenomics or other, molecular tests as Guillermo showed us in his presentation. And keeping the same idea of new technologies, I love to see and to read your paper published in it about the large language models to help, to predict bloodstream infections. But my question is about the artificial intelligence and the relationship with mentees and mentors. What are your thoughts about how to use artificial intelligence to help fellows? Or do you think that artificial intelligence can replace mentors?
Well, that's a good question. They can't, because for some things, for instance, there's a nice paper published recently on how empathic is artificial intelligence as compared to physicians, and turns out that people feel that they are more empathetic. So maybe as a mentor, it could give you nice feedback or nice words, but the other aspect, like connections, I doubt that ChatGPT will connect me to you or to Joao to develop like research idea. So it may help you to get a research idea, but that's it. That's where it stops. It wouldn't help you to get connected with all these amazing people. So I think they depends. And just speaking about LLM in particular, can be very helpful for writing stuff. Overall, I think that's the use case that I personally use LLMs for, and to summarize or information. I guess clinically it's a little bit trickier because you need to have a secure LLM as we do, but for other things like emails or just when drafting an idea for an introduction or a discussion in a paper, especially when English is not your native language, it can help you a lot to make this faster. So I think I will use it as an assistant rather than as a boss.
Yeah, I totally agree with you, and I'm happy to see your nice pictures now from conferences and all these connections. And yes, animation like Jorge Salinas, Dan Dickman, all these guys are wonderful guys, like great mentors. They change lives, definitely. I don't know if you have the opportunity to know Dr. Mike Edmond. Mike Edmond was also one of my mentors from Virginia, VCU, and I seen the picture when I think that in Mexico, in the last one of the pictures
Yeah,
that you were on the side of Gonzalo Berman.
Gonzalo, yeah.
Gonzalo, yes. Gonzalo was one of my mentors too at VCU. And Gonzalo is a wonderful guy. Originally, he's from Argentina, and he's now the editor. And
Yeah.
and that's another opportunity that mentors can give us. Gonzalo, Jorge, Mike, Dan Dikema, and I can mention a lot of others that they are in my path, and I believe that in yours too. And I'm very lucky and grateful to have these guys on my life, because that's an opportunity that they can give it to us and for our family too, because and that's the beauty of of the research, because you can collaborate together, but you can, and I love your presentation. I love it. Thank you very much, because you showed us with so many details, because sometimes we don't combine in our presentation, but I expect, details, and you gave us so many details about your personal lives with these guys, like in conferences and share things, and how impactful these guys were for you, and of course for your family. And I'm saying about me because I remember all these situations, like, and that's funny, because you know my family. We visited you and Jorge in a brief period of time at Stanford. And Pedro, my first son, my eldest son, he's in California now, and we published together our first paper. And who was there? Mike Edmond,
Mike
my
Edmond.
mentor. And that's part of the life, you know.
Yeah.
You need to share these good moments with people that you trust. And I totally agree with your comments about the artificial intelligence. Artificial intelligence, like a friend of mine in Iowa, Dr. Leon, he said that artificial intelligence is a co-pilot, just like you said. He can help us to translate things. I'm not a native American native speaker, but change my life, you know, to use it when I type my emails, like to correct your words and make my ads. I totally agree with you. And I don't know if there are more questions, please add in the chat. But I have another one that I loved to see this perspective of research in TB, CGI, vaccines, virals, fungal infections. But this one of CDI mentioned caught my attention that you during your fellow, you have a mentee.
Yeah.
And you prepare this person to apply to University of Pittsburgh and in a different position, not ID, but pulmonary division fellow. Could you share more thoughts about that?
Sure. So I think, yeah, that was a very nice interaction. I was a third year resident, and she was a first year when she started when we started working. So I think during that period of time, we explore and learn. I wouldn't say I taught her. We learned together to do statistics. We collect data together. But I think I will say that one of the things that I did the most is to encourage her to do stuff. And she already knew that she wanted to do palm and critical care, which is a very competitive specialty in the United States. So you have to have a good portfolio. So I encouraged her to work together, and we did. Besides that, that was one of the first works that we did together. But we did more focus on the interaction between infectious diseases and critical care. And then at that time, it was obviously COVID-19 in critically ill patients. And I think we also presented some research on vasculopathy or coagulopathies, I must say, in critically ill patients with COVID-19. And then I talked after I went through fellowship interviews. I help her a little bit on what's the kind of things they like to ask and how to speak about your work and whatnot. So yeah, and I guess I didn't mention, but we had a formal mentor-mentee program in my residency that was I don't know if a lot of people did it, but I mean, it was a good opportunity to take for me. And we were paired together. So I think
Okay.
that's the way we started like working.
Oh, this is fantastic. There is a program in your fellow that you need to have a mentee. For example, if you are
Yeah,
second year.
when I was a resident, yeah.
Okay.
Yeah.
And this is for research or for everything?
It was aimed for research, I think. But I don't
And
recall because not a lot of people used to do this.
oh, but pretty cool this. No, I love this. When you mentioned this about her going to Pittsburgh to pulmonary fellowship, because sometimes, you know, when students show us, they are very concerned. Oh, but I don't want to do IG. No problem. We just need
Yeah.
to understand the method of research.
Yeah, I mean that's a good thing about ID that is connected to everything, and I'm not kidding. Like as I said, one of my first papers was on voriconazole and porphyria, and I was working with the allergist, and he knew that I wanted to do infectious diseases, and he was like, "Hey, I have this case. Why don't you write it up?" And it turned out to be very helpful. So there's always something that you can find the convergence.
Yeah, I totally agree with you. No, that's amazing. And I promise you that I keep my just one question to keep you free to do your things at Stanford. But I love you to see your research because as a fellow, I believe that you don't have much or grants, to do your research. And I'm totally grateful to see your research changing guidelines. And you mentioned this link, publish this, and sometimes CDC or other societies, or you are publishing in Open Forum or CID linked it to IGSA or ICHI linked it to SHEA, whatever. And this is amazing because many times I see some researchers frustrated because they don't have money or don't have financial support, or they complain that, oh, I can't do my research because I was rejected, my project. That's a good project, of course, but was rejected to get the grant. When you apply, for example, in Brazil for the national grants or for international grants as NIA. I like to know thoughts about that.
Yeah, that's a very unfortunate situation, and I think I was lucky, uh, in some part because the salary is by any means not bad here, and I was able to some of these open access journals that I was able to publish earlier. I would just share the costs. Sometimes programs here help you with that. That happened to me in fellowship. Actually, Stanford had some money allocated for us to publish papers, but sometimes you can ask the journals. I think that's what Gustavo did. He asked open forum like, hey, like I mean, I'm from a middle income country. Look, help me here, and they did. I think Ichi is not necessarily you have to pay. Sometimes there's just they just publish your paper. It won't be open access, but I think sometimes I've seen that they make it open access either way. So it then don't be afraid to ask. The worst that can happen is that you stay the same, and you have to figure it out. But if you ask, if you get something good out of it, then you're good to go. So there's always more reward than risk when you ask for something.
Yeah, I totally agree. And wow, thank you very much for your talk. You inspired us. We learned a lot with you, with the strategic things. Like it's not easy to do so many research in so different aspects. Thank you very much, and I appreciate that.
My pleasure, Alex, and feel free to share my contact info if anyone has more questions. I see one in the chat.
Oh, let's
I
see.
don't know if you want me to answer that one.
Sure, please.
Let me see if I get it. It's important to be high quality institutions to wisely choose. How do you help other people aiming to learn in a high quality environments to also be in these places? Again, it just comes down to asking, emailing people. I have many acquaintances and friends that's what they did. They email these institutions, and there's always someone that needs help, and and you can connect, but you just don't know because sometimes they don't post these opportunities online. You just have to email people, and don't be afraid because, as I said, the worst that can happen is that they don't reply to you, but nothing will change in your life. But if they do reply to you, then your life is gonna change completely.
Wonderful. Thank you very much, Guillermo. Let's keep
Pleasure.
working.
Thank you, Alex. Hope to
Bye
see you
bye.
soon.
Take
Bye bye.
care. See you soon.